Hello everyone, welcome to HIM 216. This will be the third lecture for Chapter 2, and our goal is to finish up the lecture for this chapter in this lecture. We're on page 37 in your textbook, and we're at the point of discussing diagnostic procedures. Now we know that a secondary diagnosis can be a condition that requires a diagnostic procedure. And your textbook has some examples of different types of diagnostic procedures, EKGs, EGDs, colonoscopies, and so on and so forth. And then we have an example. A patient comes to the emergency room with pain in the leg after a fall down the stairs. So an x-ray is performed and it reveals a fracture of the tibia. So that x-ray is actually considered to be a procedure. It's not one that we code in HIM. What we would code is the procedure that would be performed to address the fracture of the tibia. Now, another secondary diagnosis could be one that actually, and I'm going to try to keep up with my slides, one that extends the length of the hospital stay. This could be a condition that might require some additional investigation or monitoring or maybe observation, which they refer to as watchful waiting. So, let's say that a patient is a diabetic and their blood sugars are uncontrolled. Maybe they came into the hospital for pneumonia and the pneumonia has been addressed. They're ready to go home from a pneumonia standpoint, but their blood sugars are not stable. And so they continue to maintain that patient in the hospital while they are attempting to control those blood sugars. And then there also may be a condition that really doesn't need physician treatment, but that needs to be monitored. And of course, that will be documented. Maybe a patient has been given a medication and they are going to do lab work to make sure that that medication's at a therapeutic level. Or there could be a condition that requires increased nursing care. And the example that they have for that in your textbook is that a patient may have a decubitus ulcer and there's no physician treatment that's actually required, but there may be nursing interventions involved with caring for that decubitus ulcer that would extend that length of stay. When it comes to previous conditions, sometimes physicians will document a condition that a patient's had in the past that is not really applicable to the current stay and not something that we would really code. Sometimes there is a V code that you can use, and a V code is those are history of codes, personal history of codes that we will certainly look at in more detail in another chapter. But in your book, the example is that a patient comes in with acute bronchitis. 2 years ago, they had an appendectomy, and they also have a history of shingles. When the patient's discharged, the physician documents the acute bronchitis, status post-appendectomy, and a history of shingles. Well, in this case, we are only going to code that acute bronchitis. The fact that they had an appendectomy a couple years ago is really not relevant to this admission, or is the history of shingles. Now, there is a personal history code that you can use for the herpes zoster, and you may be in a facility that wants you to actually code those. Now, we do code we do code conditions that are chronic or they're coexisting conditions and that have to be monitored or evaluated. And these are things like hypertension, diabetes, chronic obstructive pulmonary disease. The fact that those patients have those, they're documented, they are evaluated, those are coded. So let's look at this second example on page 38. A patient comes in with benign prostatic hypertrophy, that's BPH, and that is their diagnosis, benign prostatic hypertrophy. And they're coming in to have a transurethral prostatectomy. So the anesthesiologist is evaluating that patient, and in his preoperative notes, he notes that the patient has mitral valve prolapse and that the patient takes antibiotics prior to undergoing dental procedures. Now, this is significant for the anesthesiologist. This is a condition that's under clinical evaluation by the anesthesiologist. So we would actually add that mitral valve prolapse as a secondary diagnosis. The benign prostatic hypertrophy, the condition determined to have occasioned the admission, is the principal diagnosis. And let me say here, there is one and only one principal diagnosis. One, just one. You can have many, many, many secondary diagnoses, but there is only one principal diagnosis. And in this instance, the BPH is the principal diagnosis, and then the mitral valve prolapse is reported as a secondary diagnosis. The principal diagnosis is always listed first. So that first code that you assign and list first is the principal diagnosis. Now, in the next example, we have a patient who's admitted with acute appendicitis. And when anesthesia sees them, they find that the patient has a history of COPD, chronic obstructive pulmonary disease. In this instance, we are going to code the acute appendicitis as the principal diagnosis. The condition determined to have occasioned the admission is acute appendicitis. But as a secondary diagnosis, we are also going to assign a code for chronic obstructive pulmonary disease. We will learn in the respiratory chapter that COPD is a disease you have for your whole life, and it's a progressive disease as well. So it certainly has to be coded. Now, I briefly have mentioned integral versus non-integral conditions. And when we have conditions that are integral to the disease process, those conditions are not coded. And a big hint for this is the condition a sign or symptom? And actually, chapter 16 in the integrated code book is the chapter for signs and symptoms. We'll talk about that in much greater detail. And that would be your first hint that maybe that condition that you're looking at, if you find it in the sign and symptom chapter, is something that you may not need to code because it's integral to the condition. If it is actually not associated with the disease process, then you do code it. So let's look at these examples on the bottom of page 38. The patient comes into the hospital with a cough. So after evaluating the patient, the physician determines that the patient has pneumonia. Coughing is a symptom of pneumonia, and it is not coded. And if we would look up the code for cough in the code book, we would find that it is in the sign and symptom chapter. So if we look at the next example, the patient comes to the hospital with fever and an elevated white blood count. They do a blood culture and it comes back positive, and the physician determines that that patient has sepsis. In this case, we are not going to code the fever or the elevated white blood count because they are symptoms of or integral to the sepsis, and so they are not coded. Now, on the top of page 39, we have an example of a condition that's not integral and it would be coded. So the patient comes to the hospital and they have metastatic brain cancer, and they're coming in for removal of that metastatic lesion. When we look at the patient's history, we can see that this patient had lung cancer, and that lung cancer was surgically removed. Now the patient is having seizures. They have the metastatic brain cancer, and they have a headache. In this example, the brain cancer is the principal diagnosis. because that is the condition that's occasioning this admission. And we are also going to code the fact that the patient has seizures, and we're going to code this personal history of lung cancer. But the headache is not reported because it is symptomatic of or integral to the metastatic brain cancer. So in this instance, they're determining that these headaches are integral to the brain cancer and that the headache will not be coded separately. So let's look at abnormal findings. So what are abnormal findings? Abnormal findings are typically results that you will see when you are looking at certain types of ancillary reports. So for instance, if you're reading an X-ray report, or you're looking at a lab report, or you're looking at an EKG that's been interpreted, you may find abnormalities on those documents, and of course we would want to code them. Let's say that you're looking at lab work and it shows that the patient's hematocrit is very low. Well, a low hematocrit is usually an indication of anemia. So we would want to look in the medical record to see if the physician has documented anemia anywhere. And the guidelines tell us that we cannot code abnormal findings unless they are clinically significant. And what does clinically significant mean? It means the physician has addressed it. If you're looking at a chart and there is a low hematocrit and the physician doesn't mention it at all, he doesn't mention it anywhere in that chart, you don't generate a query and you do not code it. Let's say that when you're looking at that chart and you see that low hematocrit and you see that the patient received 2 units of blood, but the physician really doesn't address the anemia, you just have an abnormal lab test and the fact that the patient received blood. In that instance, you actually can query the physician to ask him if the low hematocrit and the fact that the patient received blood if there's a diagnosis that can go with that, if the patient had anemia. Now, there is a little bit of an exception to that, and we'll talk about it more as well, and that is, let's say that the abnormal finding provides further specificity. Let's say that a physician diagnoses a patient with breast cancer, and when you read the pathology report, the pathologist tells you specifically what kind of breast cancer. You can code to that specificity. Let's say that a patient has a fractured femur, and in the radiology report it tells you specifically that it's the head of the femur. You can use that specificity when coding that fractured femur. But if you looked at a radiology report and it said they had a fractured femur and nowhere in the chart did the physician address a fractured femur, then you couldn't code that fractured femur. Now I want you to turn to page 48, to page 40. And we're going to talk about coding from the documentation that is found in that health record. Typically, when coders sit down and code a chart, they start with the discharge summary. And then once they look at the discharge summary, then they maybe go to an ER record, then a history and physical, any other reports dictated by physicians, maybe a consultation report or an operative report. You look at the daily progress notes, and you also look at the physician orders. And there are times when you look at other documents depending on what you're seeing. For instance, if a patient has decubitus ulcers, you can use nursing documentation for the stage of that particular decubitus ulcer. If a patient is obese and the physician has documented the obesity, and the dietitian or a nurse actually documents the BMI, the body mass index of that patient, you can use that information to code from. But typically when we are coding from physician physician-generated documentation. There are always a few exceptions to that. For instance, if a patient's on a ventilator, we go to the respiratory therapy records to actually look at their very specific documentation about the time that the patient was on that ventilator. But usually we're just coding from physician documentation. And so then we need to know what are we looking for? Obviously, we are looking for our whole point in coding this record is to determine the principal diagnosis, the principal procedure, and then all the secondaries. We use these documents, number one, to determine what the admitting diagnosis is, and then the principal diagnosis, and then the principal procedure. The physicians whose documentation we can review is any qualified physician who is treating that patient, and that is attending physicians, consulting physicians, anesthesiologists, interns and residents. The documentation that we don't use is medical students. Medical students have not completed their training. They are not licensed. They are not independent practitioners. Many facilities also have nurse practitioners and physician assistants who are also documenting in the medical record, and their documentation can also be used for coding. And then there on the top of page 41, there is more information about coding from radiology and pathology reports, because of course radiologists and pathologists are physicians. They are licensed physicians. I want you to look at we're going to go through the examples on the bottom of page 40. And in this first example, it's talking about using the ER form. The ER form is basically a history and physical, and it can be quite extensive. And it usually lists the reason that the patient presented to the emergency room, as well as a past medical history, which would be lists of their other medical conditions. The ER physician completes that form, sometimes circling any pertinent diagnoses. And in this example, the physician has circled end-stage renal disease. Now, end-stage renal disease is for patients who are in kidney failure. These are patients that require dialysis, and they often are on a kidney transplant list. But when we look through the body of this health record, we can't find any other documentation of end-stage renal disease. It's not anywhere. There's no documentation that the patient's receiving dialysis or that they're waiting for a transplant. The only documentation we can even find related to the renal system is chronic renal insufficiency. And there's a huge difference in the coding for these. And there are examples of the codes here, which probably don't mean anything to you at this point in time. But there's a big difference in end-stage renal disease and chronic renal insufficiency. So these are examples of when you would need to query the attending physician. And the attending physician's probably not going to be very happy with that query, because if a patient has end-stage renal disease, it is usually very well documented and the patients are monitored. In the next example, it says throughout an inpatient chart, it's documented that the patient has a past history of pneumonia. Also, when we look at the history and physical, one of the areas of a history and physical is past medical history. It's documented there. There was no chest x-ray performed. On the physical exam, the lungs are clear, but on the discharge summary, the physician documents pneumonia instead of history of pneumonia. Well, there's a big difference. Pneumonia is a current acute condition, and if a patient has pneumonia, you certainly expect it to be evaluated and treated. And the difference is the acute code versus a history of code. So you would want to get clarification and documentation for that. In the next example, there is documentation of end-stage liver disease, ESLD. There's also documentation that the patient's waiting for a liver transplant, and that this patient does have a history of cirrhosis and hepatitis C. But in one of the progress notes, it says cirrhosis, hepatitis C, end-stage kidney disease, but there's no documentation anywhere in that chart that the patient has end-stage kidney disease. So this is probably just an error on the part of the physician, and you would generate a query asking the physician to clarify that documentation. So now that brings us over to page 41. That actually talks about using queries as part of the coding process. And the purpose of a query is to clarify documentation. Our goal in coding is to code as accurately and completely as we can. As a matter of fact, there are recommendations that coders not code records that are not complete. And in reality, coders do code records that are not complete. However, if the documentation in the record is such that the coder does not feel that there's enough information there to be able to code that chart, they don't code it. They flag it, they put it to the side, they wait for the additional documentation. And a chart could come in missing an H&P or a discharge summary or an op note, and the coder could say, nope, I'm not coding this until I get this additional documentation. And so then once the documentation is available, then that chart is recycled back to the coder to be coded. But the purpose of the query process is to clarify documentation. Every facility should have policies and procedures related to query processes. This is a huge issue. It is CMS actually has guidelines based on the query process. Queries are typically accomplished using a form, and the purpose of the form is to obtain the additional documentation from the physician. And actually in your course, in course syllabus and information, you will find the most recent document that AHIMA has published that discusses the query process and actually has examples of query forms. And AHIMA has guidelines for how these forms should be completed. When queries are created, they need to become a permanent part of the medical record because it is documentation that is used for coding. Coding drives reimbursement. So it really has to be a part of the business record. In order for these documents to become a part of the medical record, they typically are taken to the medical record committee. The medical staff reviews them, they approve them, and they become a part of that medical record. And it doesn't matter whether they're paper or they're electronic. That is the same process that needs to be followed. Now let's look at this first example on page 41. The patient comes to the ER from a nursing home with hypotension, fever, an elevated WBC, and a high respiratory rate. The ER physician documents pneumonia. In this instance, these symptoms, these signs and symptoms, are actually indicative of sepsis. So the query would be for sepsis because the patient has clinical evidence that meet the SIRS criteria, and that SIRS is systemic inflammatory response syndrome, and we'll actually discuss that in chapter 9 this semester. In this next example, a patient comes in with cough and fever. They do a chest x-ray. The patient is started on clindamycin, but there's no diagnosis documented. So we would generate a query for a diagnosis or for the reason that that patient was started on antibiotics. So we have a treatment but no corresponding diagnosis to go with it. Now on page 42, we have a patient that comes in the ER with abdominal pain. They have gastroenteritis. They have hypokalemia. So in the discharge summary, the physician documents hyperkalemia. So this is conflicting. The patient had their potassium was low, not high. So we would generate a query to get clarification on whether or not that patient actually had hyper or hypokalemia. And then in the next example, there is a process called present on admission that can impact reimbursement. And so as part of our coding process, we actually identify which diagnoses were present on admission and which were not. So in this particular example, on day 2 of the hospital stay, the physician documents that the patient has a UTI and he begins antibiotics. So the question is, did this patient have a UTI on admission or not? Is this a patient who came from a nursing home, already had a Foley in, and when they came in, they ordered a urinalysis with a culture and sensitivity, and they just got the results back and they're diagnosing the UTI? Or is this maybe a patient who came into the hospital and developed the UTI after admission? And since this says day 2, it's probably really unlikely that the patient ended up with a hospital-acquired UTI by the 2nd day. But your book has it as an example, and so we would generate a query. And I will say that there are, if some of you are experienced, you know that you'll recognize that some of the examples in the book are probably not real likely, and you, in your actual practice, coding practice, that is not something that you would typically do. However, the examples in the book are simply that. They are examples, and sometimes you're like, well, no, I would not do that. But we go with them, we go with the flow because they are in the textbook. Now, when we are querying physicians, in reality, as a new coder, you will probably not be in a position to generate queries. Most facilities have policies and procedures about queries. They have a supervisor, maybe a DRG supervisor or a coding supervisor, who actually reviews any query that's generated to ensure that the documentation really is not in the chart. They want to make sure that that query is appropriate. Queries are tracked. They're tracked by coder. They're tracked by physician. They're tracked to look for trends, maybe physician documentation, education opportunities. So they are definitely documents that have to be monitored and maintained. Many times a chart cannot be billed until that query is completed. So queries that become a part of the medical record, and they also add to the deficiency listing. So if a physician has a query and it's been on the chart and that chart hits 30 days old and that query is not completed, a physician can be suspended because they have not completed their queries. Your book says that queries can either be verbally or in writing. If it is a verbal query, and I actually do not know of many facilities at all that use verbal queries, but if it's a verbal query, that the results of that conversation or that discussion should be documented immediately. It should include all the same information as a written query, and it should be maintained as a part of that medical record. And your chart talks about how queries should be maintained if they're not a part of that medical record. The query format, they can actually be open-ended. They can be in a multiple choice format. Sometimes they can be yes, no, and yes, no queries are typically used for present on admission. They have to, whatever format they're in, they really should be reasonable. They should be supported by clinical indicators. You can, when you use the format, you can have additional options for the physician to select, such as clinically undetermined or not clinically significant. And then your query should be retained for the same amount of time that you are maintaining your medical record. So whatever that policy is typically should be the same as your other paper and electronic medical records. On the top of page 43, your textbook talks about leading queries. And these are queries that potentially may not be supported by clinical indicators, or they direct the provider to certain to document certain diagnoses or procedures. There is a practice brief that AHIMA published that is actually, this is the practice brief that's included in your course documents, guidelines for achieving a compliant query practice. And then when do you query? Basically, you query anytime there is questionable documentation. You can query any of the physicians who are involved in the, well, you query the physician that generated the documentation that you have a question about. Your textbook on page 43 talks about the elements of a query form, and actually this should be defined in facility policy, but at a minimum, though it should always include the information that's listed here. You need to know the date of the query, specific information about the patient, that patient's admission date, and then the specific information that needs to be clarified. Now, your question for this lecture is, what is a leading query? How do you identify a leading query so that you can make sure that you're not generating queries that are considered to be leading queries? And that will conclude this third and final lecture for Chapter 2.